Hello, everyone. Good afternoon to our November 25th Prescription Drug Affordability Board meeting. I'll call the meeting to order now. Just want to make sure we have a quorum. I know we have a couple folks virtual today. Joe, you there?
I am here. Hi, Van. Can you hear me?
Yep, we can hear you. Good to see you.
You too.
How about a Barry?
Hi, Van. I'm here. It's Barry.
Thank you. Hope you feel better. Jerry?
Here.
And Stephen?
I'm here.
And myself. So quorum present. I'll look for a motion on approval of the October 28 minutes that were submitted online and to you earlier this week.
So moved.
Moved by Jerry. Is there a second?
Second.
Second. Any additions, corrections, changes? Hearing none. All those in favor, aye.
Aye.
Opposed?
Hi.
Thank you. Ayes have it. Item number 3, opportunity for public comment. Christina?
Thank you, Chair. The board received one written comment. This was shared with the board and also posted on the website. No one registered for oral public comment today.
Okay. And everyone got a copy of the comment, right?
Correct.
Received a copy. Okay, item number 4. Staff going to do draft regulations.
There we go. So the first order of business for us is to go through. Tanisha, is there a speaker I should turn off or anything? Maybe. No. Do you want me to try to present from over there and see if it helps? Here, I'll try another speaker real quick. All right, how does it sound now? Testing, testing. Okay, perfect. All right, thank you. Sorry about that. I think we got it, Mr. Chair. Yep. All right. We wanted to present the draft regulations to the board. So we'll just go through the comments that we received and give an overview of where the regulations are. So just for the board's reference, you'll remember that we worked for a substantial amount of time on the upper payment limit action plan. So that was the document that we created that basically outlines how we would go about implementing the upper payment limits. We presented to, so you approved that action plan to go before the Legislative Policy Committee on September 10th. The Legislative Policy Committee convened a meeting on October 22nd, and we were able to present to them. And they ultimately approved the upper payment limit action plan. So the next step for us to move forward in this process is to adopt regulations that establish the process that we outlined in that action plan, specifically the policy review process that we articulated before. So to implement this process, we have 3 separate sets of regulations. One is the first is an amendment of the definitions. We just had to add a few definitions to cover this process. And then we created a new regulation for our hearings procedures, and then also ultimately a new chapter for the policy review, final action, and upper payment limits. The draft was posted on October 28th. And we received comments on November 8th. And again, this is a process to allow the public to provide some initial input. This does not circumvent the standard comment and notice and rulemaking. So this is primarily, again, to give the public a chance to provide input, and we very much appreciate the input that was provided. We got a lot of really good substantive comments. Those comments included 16 comment letters that were received and shared with the board and posted on the website. I believe it made up about 85 pages of comments. So I wanted to just spend some time going through the comments and then also very much welcome the board providing any feedback and insights that you have related to the comments that we received. So at a very high level, we received some very good feedback. At a high level, there was the overall feedback that we have on the left. So there were some general concerns with upper payment limits as a policy tool. There was also concerns with the impact of upper payment limits on access, patient cost sharing, and the supply chain. There was a lot of feedback just on the process for going through these regulations. A lot of folks were concerned with timelines and the speed of which we've gone from developing the upper payment limit action plan to the regulations to hopefully or potentially approving those regulations. And then also, we did get a lot of specific feedback, and we very much appreciate the specific feedback and try to implement the specific feedback whenever we can. So I will just flag that. So with a lot of these, so again, different from the federal process where we kind of respond to every comment that comes in. Well, this is also an informal comment process, but I did want to just verbally try to address some of the comments that we received. So we did get some good comments specifically around some definitions. There was some discussion around what the definition of utilization should be, especially in terms of determining one of the criteria, which was utilization by eligible entities. If that's a minimal amount, then we wouldn't set UPLs for those drugs. So we did clarify that. There was some questions about the definition of the term affordability challenge, and we did have a clarification, just the way that it's worded in the definitions. I'll show you that when it comes up. Some good questions on net ingredient cost, and that's actually where we spent a lot of our time trying to revise and clarify what the policy is. And then we did get some good comments on the hearing regulations, the APA process, an APA process clarification question, and then also finally a request for specific timelines. So I did want to just take, again, some time to specifically go through some of the comments that we received. First, in the terms of the definition of the affordability challenge, I think some folks had concerns with how it was articulated in the document, and we just wanted to clarify that when we say affordability challenge, we are actually just creating a shorthand that we can then use throughout the policy process, rather than having to copy and paste has led or will lead to affordability challenges for state and local government and or high out-of-pocket costs for patients, right? So basically what we did in that process, so I just wanted to clarify that for a lot of the comments that came in. It's functionally creating a shorthand the way that we drafted it. Next, we on the hearings regs. So this was actually a really nice conversation that we had during the stakeholder council meeting as well. So as you'll know, we have a couple tools to gather more information, and we'll go over this shortly, but one of the most important information gathering tools we have as part of this policy review process is hearings. And there's a couple different types of hearings, but the purpose of the regulations is basically to create the standards and guardrails that we will follow for multiple types of hearings, if that makes sense. Sorry, I'm looking over at council because I need to be careful how I say it. There are different hearings with different types of purposes that may have slightly different formats and things like that. So just as an example, during the stakeholder council meeting, there was a request to put in, for example, times that folks can speak, like a set amount of time that folks can testify during these hearings, or certain times for notice in terms of how far ahead of time you would provide notice on hearings. And we carefully considered all of those comments and ultimately felt that it was actually in the interest of the public to maintain the structure that we have, because each of these hearings may have a slightly different format, basically. So just as an example, if we have a hearing where we're trying to get just public input and we want them to just share all of their thoughts and feedback, we may set a much higher time limit than we would if it's a hearing to get specific feedback on a specific issue, right? So we just needed to leave the flexibility in the regs, and we were worried that if we constrained them, they would actually end up harming us and preventing us from holding a certain type of hearing that we wanted to hold. So that's a general feedback that we wanted to address. There was also the comment, someone flagged that we do have the ability for the board chair to hold on repetitious comment. That's a term of art that exists in a lot of these hearing languages. So we left the language in, though ultimately this is something that the board may decide otherwise on, but it's since it's a term of art that's commonly used in this hearing language, we thought it was important to keep it, because again, it's a tool for the board to basically manage expectations and make sure it's also respecting everyone's time to ensure that you have the tools necessary to hold the hearing in a way that the board wants to. There was some questions about following the APA. So again, as I mentioned, these informal comments for this draft that we posted was not part of the APA process. This is before the APA process. This is something we've layered on top of all the existing comment procedures and notice and comment. Again, just to try to err towards giving the public more time to provide feedback. So we did want to confirm that the APA is still in place, and for example, if these regulations are published, they would follow the standard APA process. Let's see. There was a lot of questions from folks that are kind of in the work within the supply chain on just exactly what was represented in terms of our net ingredient cost. There was a lot of discussion to make sure that anything that we do around upper payment limits accounts for things like administrative costs to acquire the drug, store the drug, maintain the drug. I think one of the examples given was insurance for maintaining the drugs. And I guess our response to that, it didn't require a regulatory change, but basically we are defining it as prescription drug product, which covers all of those items. And the way that we've thought through how the upper payment limit will work for state and local government, it doesn't really bring up the issues that they are concerned with. I think at a high level, they're concerned with making sure that any amount paid is basically above the acquisition cost plus a margin for management and administrative fees. We don't picture the amount going to them to change through this process. We are proposing that it happens with rebates on the back end. So we don't picture that to be an issue, but it may be something that comes before the board in certain circumstances. Let's see. We did get some questions specifically, this came up in the PDAS meeting too. And so just one example, we have a criteria on why we include 9 generic drugs. And we did go over the literature again. So the debate is, at what point do you have enough generic competition that you've kind of reached the steady state of that being a low cost drug? There's a few numbers out there. I think 5 is the most common one, but we did review the literature and it seems like 9 is the appropriate threshold, but this is something that we can talk through. But we did confirm that 9 is a kind of guarantee that we've reached full generic competition. And then let's see. So I think that's kind of at a high level some of the comments that we received. I'm gonna go through this presentation pretty quickly and just flag the changes that we've made based on these comments. But then I do encourage the board to discuss and we're happy to respond to any of the comments that you had questions about. We did feel like we were responsive to all the comments that we could make changes on. And a lot of them are addressing kind of operational issues that we're taking into account for the actual implementation of the UPLs, but is not something that could have been addressed in regulations. So happy to have that discussion when we get to that part of the presentation. So just going through and flagging the different changes that we have. So, and then also the stakeholder council feedback. The stakeholder council had a really nice discussion on November 4th. They reviewed the draft version of the regulations, and I think they did not see the comments that came in. So they were kind of the first kind of showing of public comments that we could have received. And same overall issues. There was a lot of discussion around clarifications on definitions, some questions about the hearings, logistics, and procedures, some questions just on general milestones and timelines for setting upper payment limits, ensuring that we're meeting consumer expectations and not necessarily, we're careful on communicating exactly what these upper payment limits will do. And then there were a lot of questions on how the suspension process will work as well. So that's all articulated in the regulations. So ultimately, it did take a lot of time, but the actual changes to the regulations are, they are generally consistent with the draft version that was submitted. The biggest thing that we spent time on was a clarification of the definition of upper payment limit. So this came up in the stakeholder council meeting and then also was further articulated in a lot of the comment letters that we received. Basically asking, like, what is the upper payment limit number that the board is setting? And we had originally said that it is the ingredient amount paid by the eligible governmental entity. And basically what was brought up in the conversation with the stakeholder council and then further articulated in comments is that you need to be able to account for the upper payment limit, or you need to be able to account for out-of-pocket costs in the upper payment limit that the board is setting. I guess as a extreme hypothetical, just to articulate what the problem was, is if we set the upper payment limit, it was just what the payer was paying, you could theoretically change the out-of-pocket cost for the patient, so the ultimate cost that goes to the healthcare system is the same, it's just more borne by the patient, and obviously that's kind of the opposite of what we want this UPL to do. So what we've changed is basically the amount that is set by the board is the amount we say to the healthcare system, but basically the net cost of the healthcare system, which is basically out-of-pocket costs by the patient plus what the payer is paying. So that is the number that you're adjusting. And when you adjust it, when we calculate the amount that the payer is paying, it's basically that new amount minus out-of-pocket costs equals what the payer is paying. The reason this is important to articulate is because it's no longer a exact number that you are giving to payers anymore. You are giving the total cost of the healthcare system, and then it's ultimately up to each payer to apply it to how their plan design works. Since we're working with eligible governmental entities, we will be working very directly with them on this policy. But it is something that we just wanted to flag that kind of changed the definition of how that worked. Happy to answer questions on it. I know it's a very complicated topic, and we spent a lot of time trying to flesh that out. And we also got a lot of really good, just concrete questions on some of the definitions. And one of the ones we were able to directly address is there was a lot of questions around, I think one of the criteria is you shall not set a UPL for drugs that the eligible governmental entities have minimal utilization. That's not the exact wording, but the issue is utilization was the key term, and then also minimal. Folks were asking, well, what is that? So we were able to update that definition and clarify that it's based on spending, so it's the spending of the drug, and minimal, we've defined it as if the amount that the eligible entity spends on the drug is more than the administrative cost to administer a UPL. So basically, will there be a net savings to the entity by going through this process, or will it cost them more to implement the UPL than they would save through setting a UPL, basically? So that's the main definitional change we were able to make. And then we did add a couple terms just to articulate the thing that I mentioned before. So we did create this new term called the eligible governmental entity upper payment limit, which is the subset of the upper payment limit that the eligible governmental entity is responsible for. So at a high level, those are the big changes that we have. And I'm happy to go through the regulations. I guess I can open it up for some general discussions of the comments. Would that be helpful, Mr. Chair? Yes.
The definition is actually, the board will not set the UPL if spending on the prescription drug product by the eligible governmental entity is less than the administrative cost.
Great, thank you for clarifying, yes.
Are there any questions? this point? Jerry?
There. So I just basically think that, having looked through all 85 pages, and I really want to compliment all people that actually made those comments. I found the specific feedback much more helpful in some ways than the overall feedback. Really getting the words correct, getting the concepts correct. I think, when we were working on it, as members of the board, we thought we had really good definitions, and I think the comments that we got really did improve the methodology and raised issues that, I hadn't considered. So I think that it was a significant improvement. The concerns about, how long it's taken or how fast we are now moving, I would just remark that we started this process 4 years ago. We started this process in intensity a year ago. So, these are not fast steps that we are taking. These are slow and deliberate steps that we are making. The issue of, what is the net cost, we spent a lot of time trying to figure out what is the net cost and how do you define it. And I think it does make sense to define it the way that we have done it. But, if there was another way to do it, I think, we could do it a different way. But I think the way we've done it, including both, the cost to the patient and the cost to the state, makes sense. It could get a little tricky if the state has two different health plans and they have two different cost-sharing arrangements, and and they don't make it titrated so that it comes out to the upper payment limit. I think we'll just have to work with the state on that particular issue. But aside from that, I think I really do appreciate the detailed comments that we got.
Stephen?
No, I'll just echo what Jerry said. Things are complex, to be sure, and I compliment the staff for all the work that went through to get these things in an order that really does make sense.
Great. I see hand up from the Barry.
Thanks, Van. Can you hear me okay? Great. Also wanted to echo my appreciation for the obvious time and consideration that various stakeholders, quite frankly, have put into providing us with these comments. It was very helpful to go through them and understand the perspective that different stakeholders are bringing to our discussion. And I think really allows us as a board to be inclusive and try to come up with processes and procedures that represent the sum of comments received. And I might just offer some general thoughts having gone through the document. Andy, thank you for the overview. A lot of what you identified as general themes aligned with my list, if you will. A couple more things that I might point out coming through the comments was certainly there was a call for more specific definitions. There was also requests for contextualizing our decisions. So I see that there is a bit of a tension, which is part of the process, so quite expected, but a tension between being mechanistic versus really considering the context of utilization and patients and providers' decision-making and so on. And that's a line that we are aware of and we will pay close attention to, is when can we be more formulaic and uniform versus when do we want that additional context. And so it was interesting to see that come through in the comments. I also wanted to clarify, because there were a couple of comments that seemed to imply that we're conducting de novo analyses. Our approach until now is not to conduct de novo analyses, right, to support these decisions. but that we will be using available published evidence, whether it's to support reference pricing decisions or thinking about threshold or even with the cost review, that we are not doing that number crunching. So I did want to clarify that. So what that means is we are going to be beholden to what is published. Several of us understand that publications occur with lag. And to the extent we can use gray literature, that could be something we think about too. But I wanted to note that. And maybe just on that point, the question around the threshold of 9 that Andy had mentioned earlier, I did see those comments come through, and that could be something just for the board to provide to the public, is what were those literature citations that supported the choice of 9. A quick word on the reference to repeated testimonies. The way I read that, and while it was fine to me, was I distinguished duplication from really repeating, and repeating is, to me, acceptable if multiple perspectives are weighing in on the same topic. I wouldn't call that repetitive, and I would welcome different perspectives, even if it's on the same topic. And then I just had a closing comment about informational hearings, which I'll come back to after I finish my summary of the comments provided. The other thing I saw come through quite a bit, which I just want us to be aware of, is really this call to integrate the patient perspective throughout our process. And to me, that begins before we even get to the UPL stage. And that's why I'm really intrigued by the possibility of using these informational hearings in the cost review process, and not only have them, coming through at a later stage. And something I'd also be interested in that cost review process has to do with another comment we got. Well, I would say sort of another set of tension type comments, where on one hand we were being asked to pick one method for setting a threshold, be clear about it, and stick to it, regardless of the decision in front of us with respect to drugs. And then we had other comments talking about applying more of a deliberative approach. A couple mentioned MCDA and other approaches. So I can kind of share my perspective on that, which would be that I don't consider that the method is enough to determine the quality of the output of our decision. And there are very good methods we have for several of these decisions ahead of us coming out of the health economics literature. But their ability to really drive strong decisions also depends on the inputs and the data sets and the measures. And so if the method was enough, I would be in favor of picking one method and really anchoring to that. But my bias would be towards understanding the quality of inputs for each of the methods, and then thinking more deliberatively about the different methodologies for setting a threshold, or the different criteria for thinking about reference pricing. And then to that end, this gets back to kind of my closing comment, I would be interested in the context of these informational hearings to have individuals come through who've done a lot of thinking about deliberative decision-making within and outside the healthcare setting, to come to present to the board, so that we're hearing certainly from patients and other stakeholders, but also hearing on methods for decision-making during those hearings.
Great. Thanks, Barry. Jerry?
Let me just amplify a little bit of what Barry said about the 9 generic drugs. You know, most of the literature would suggest 4 or 5 is sufficient, but that assumes, A, that they are actually being marketed and being marketed effectively. And so, you know, you're concerned about that. And also, it could be a drug that the generic is owned by the branded company, and so there wouldn't be real competition there. So, you know, sort of, we could, you know, have a formula for these things, but what we have to recognize that each drug has some unique features to it. And so having a very specific formula, I think we have all agreed on these are the factors that we're going to use, but a very specific formula, just as simple as, should there be 5 or 9 generic drugs is a problem. So we essentially chose a very conservative approach of using 9. I think we could have easily chosen 5, but it might be that all 5 of them are owned by the branded company, or they have chosen to have pay for delay, and there is no generic company that's actually selling the drug. So I think having 9 makes sense, but it's an example of why you have to have some flexibility in how you're proceeding.
Michelle?
I just wanted to correct the record in the draft regulations at Comar 1401-0504D4, which goes through the policy review information gathering process, D4. It does include mechanisms for board staff to conduct research and analyses, and that can include research, may include a literature review of available literature and original quantitative or qualitative research conducted by staff. There are other parts of the draft regulations, 06D, referring to the development of the UPL, where staff do perform analyses and calculations. So just wanted to clarify that there is, I guess, some original calculating and analysis being done by staff.
Thanks,
Thanks for
Michelle.
that,
I
Michelle.
appreciate that. I was going to ask that actually as a question. And then maybe in addition to that, in the information that is being provided, confidentially as part of the cost reviews, I wanted to just clarify that there would be able to be some calculations done with that information. And I mentioned that just to sort of say, it's very helpful for us as a board if for these drugs that have been selected, people should make their sort of value cases, or manufacturers should make their value cases to us, both with public and potentially with non-public information about, the quality of this particular molecule compared to other molecules. And I think there was a lot in the comments that was, concerned that we were going to be building value models that are going to show, ineffective treatments, and that we set UPLs, too low. And I think I just wanted to make the case that to the extent that there is evidence that exists that is sort of well known to the manufacturers of the particular drugs, we want that evidence. We want to see, how well this works relative to alternatives. And that will be sort of taken into account before, the decision to set a UPL or not. It's sort of, we want clinical evidence, and we want all the evidence that we can possibly have to sort of make the best informed decision. So, partnering with the manufacturers, hopefully, sending us this information seems like a critical piece. And I just wanted to echo everyone else's comments. We really appreciated the thoughtful feedback, and I think it's been incorporated quite well.
Thanks, Joe. There's another question from Barry, or comment?
Yeah, more of a comment too, and thanks for the clarification as well on the data piece. Mine is a comment around our conducting analyses, for example, to support whether it's prior steps before UPL or even in the UPL stage. We've talked earlier about the availability of data, and so I wanted to just bring that up for discussion too, because if it gets more recent, then I'm more confident that we can speak to current burden. And then otherwise, we're sort of back with the same constraints, if you will. But I did want to echo Joe's comment around just a call to our stakeholders that if they have more recent data, because that's been my concern with parsing available data we've had to date, was the age of it. But stakeholders may have more recent data, more recent evidence, whether it's qualitative, quantitative, I would love to see us produce de novo results that are customized for Maryland, but I also recognize some of the challenges and limitations with that. Hence my support of that call.
Great. Anybody else? Andy?
No other questions. Yeah, I appreciate all the feedback from the board members and bring up a lot of great points. So we appreciate their close review of the comments and discussion of the issues you addressed. So I think what we can do now is briefly go through the regulations. It largely reflects what you've already reviewed in the regulations themselves, but I will try to go through them just so you have an idea of everything that's in there. And I'll try to also flag the updates that we've made as a result. So this will look familiar. This is similar to what was presented to the Stakeholder Council with the major, primarily the updates. And again, feel free to stop me at any point throughout. I think it's probably easier to discuss specific points if you see anything that you have questions on. So again, just as a general overview of regulatory structure, we are in Title 14, which is independent agencies. We are Subtitle 01, which is the Prescription Drug Affordability Board. We have some different chapters that we that address through these regulations. But just as an example, 01 is our general provisions, and Regulation 1 is definitions. Just some COMAR 101 for folks. So in Subtitle 1, you can see that we have our general provisions. These are the subtitles. We have general provisions, the fund that you are probably well aware of now, Public Information Act, the cost review process, and then our new chapter, or our new section, which is the policy review, final action, and upper payment limits. So the amendments in the definition, I summarized the 3 changes that we made. We ended up defining purchaser, which means an entity that it purchases the prescription drug that's not a payer or a patient. And we did receive some comments kind of asking for clarification on this, and it is intentionally worded the way it is to cover the different entities that can serve in that role. We had to define system net cost, which means the sum of the net cost otherwise defined, and then the per unit patient out-of-pocket costs. And then also we have a definition of utilization, which means information for the use of the drug, including the numbers of units, number of patients, and the number of prescriptions or claims. So again, basically non-spending metrics that we can use. Any questions on our changes in the definitions? Okay, so then we also added the new regulation, which is our hearing procedures. So it has the 5 or 6 different parts: the scope, the general hearing provisions, the informational hearings, technical hearings, the recordings element, and then also the hearing record. Oops. So we didn't go into the depth on these, and there were no substantial changes, though we did receive a lot of comments on the hearings process. Again, we carefully considered all those comments and tried to identify ways to better clarify or further define the hearings regulations. But we think that they, as are drafted, kind of meet the needs of the board, especially because we use the informational and technical hearings for a few different purposes, basically, and they may look slightly different while still following the framework of these regulations, depending on how that goes. Any questions on our hearings procedures?
No, just that, aren't these pretty much structured throughout the state in other boards and commissions?
Yes, and these are largely modeled on the Department of Health's hearing procedures. Again, not contested case adjudications, but hearings held for the purpose of receiving public input in the development of regulations, policy, et cetera.
Great, thanks.
And we do think this will be an important tool. It's a tool that we wanted to use earlier in the process, but didn't have this set out. So we're excited to have this as a tool that we can use forward. And then also I wanted to address Dr. Nukuga's point on using these kind of earlier in the cost review study process. And that's certainly something the board can address in the future by updating your cost review regulations to say you can use hearings to gather information. So once these regulations are in place, you can look at other opportunities where you may want to include them elsewhere in the process. So we can bring that up to you in the future. Next up is kind of the meat of the regulatory changes. So we have these 9 different parts, starting with definitions. We also have the criteria for setting upper payment limits, the policy review and final action process. Then we further articulate the information gathering, the preliminary policy recommendations, the process for establishing an upper payment limit, final policy action, and then the establishing and monitoring UPL, and then finally the reconsideration process. So we like to kind of start with our flow chart, and I know we've done this in a few different formats, and it's always you know, a long process to walk through. But at a very high level, your cost review study regulations have been amended to allow for a preliminary determination of affordability. So instead of that being the final action of your cost review study, this is now kind of an intermediate step where the board makes their preliminary determination based on the information that you have. If you say that there's the drug does not cause an affordability challenge, then there's no further action. If the board says that it may create an affordability challenge based on the data that you have, we then move into this new process that's articulated in this part of the regulations. And the first step is to identify the drivers that are causing the affordability challenge, and then also recommend the different policy options. And then we have the 2 buckets of policy options, non-UPL policy options, and then ultimately the upper payment limit policy option. We did get a number of comments, again, indicating that folks are concerned that the board seems to overemphasize the upper payment limits, and I would, it's a point we've made a number of times, but I would just state it again, that at least from the staff perspective, we picture all policies to be on the table, so we treat this blue non-UPL policy option process in the same light that we treat the upper payment limit policy process. The reason we have to be so specific on the upper payment limit is because that's what our statute calls for, and that's the most direct tool that's available to the board. But we do expect to put a lot of time and resources into the non-UPL policy processes. So again, just walking through verbally. So if we, for the non-upper payment limit policy options, so the staff will gather information on potential policies, then we'll identify the drivers that are causing the affordability challenge and the policies that most directly address those drivers. And I'm down here on the bottom, on the blue slide. Ultimately, staff will bring those recommendations and the justifications to the board. The board can then provide feedback on those policy recommendations. And then staff will update our recommendations based on your feedback and propose draft resolutions. And then your final action for non-UPL actions would be to adopt resolutions in a board meeting. So again, some of these policies may not be, maybe recommendations for other partners, whether they be legislative or executive partners, to implement different policies. So those would come out ultimately from board resolutions. The other process, which is what the substance of, well, the primary, what a lot of this chapter addresses is the UPL policy options. So again, the first thing that the staff will do is gather information for the upper payment limit. Then the staff needs to recommend that an upper payment limit is an appropriate tool, and then provide the options or the recommended methodology. Then the board, so that document will be published and we'll get public feedback. And then the board provides your own feedback based on what the staff presents and also the public comments that you receive. Then staff can take that information and actually make the calculation itself. That would then be published for public comment and ultimately brought to the board for approval. This process also has technical meetings or technical hearings. And this is specifically to address what we expect to be very technical and nuanced discussions around methodologies. So we did want that to be it's kind of its own separate type of hearing where we can have a very engaging discussion with the folks that are providing that feedback to the board. Ultimately, if we make updates based on the feedback that the board provides and also from the technical hearings, we would then publish the final version, the final calculation of the upper payment limit. Ultimately, the public would also still be able to provide comments on any version that we publish before it goes to the board. And then the final action for the board is to update the UPL as a proposed regulation. So we are doing this. Each UPL that you will set will be published as a regulation. So that's a very high level of the process, and that's ultimately what we try to articulate throughout these regulations. So I'll try to go through these as briefly as I can. So in the definitions, we did have to, 3 definitions that we wanted to flag as changes from the draft version that was published. Again, we created this definition of eligible governmental entity upper payment limit, and that gets to the concept that I had mentioned before, that when you set an upper payment limit, you're setting it for both the out-of-pocket cost for the patient and the eligible governmental entity. So that subset that the governmental entity provides just for our communication and working through the process, we needed to give its own term. So that's that there. The system net ingredient cost, we did receive a lot of good comments on this, and we had a lot of discussion here, and we ultimately define it, as I mentioned before, the final system cost attributed or related to the prescription drug product after accounting for all discounts and price concessions, excluding dispensing fees and administration fees. And then also we did exclude direct and indirect remuneration to pharmacies. And it does include out-of-pocket costs. So that's what we spent a significant amount of time working through. And at a high level, that's what I talked about before. We're talking about the UPL being the, reflecting the system net ingredient cost. One note just about the indirect and direct remuneration to pharmacies. One of the reasons that's excluded is just because that isn't necessarily specific to a drug product. It's ultimately usually metrics that are given to the pharmacy as a whole. So we thought that it was difficult to kind of link those in, so those are excluded. And then I think, and through previous discussion, we decided that the dispensing fee and then any administration fees are separate from the ingredient costs. And then you see this new definition for upper payment limit means the amount established by the board and represents the system net ingredient cost. So again, at a high level, it just makes sure that we include the amount that's paid by the payer and also the amount that's paid by the patient in out-of-pocket costs. All right, so moving from the definitions into the actual process. So our criteria generally remained the same, and this is largely articulated in the upper payment limit action plan, and then also in the regulations. So I'm not going to read through them. I'm just going to flag that the changes that we made, let's see, is on the next slide. So we were able to update the board shall not set an upper payment limit if the spending on the prescription drug by the product by the eligible governmental entity is less than the administrative cost to implement an upper payment limit. So that's ultimately what we were trying to get at with our previous language, which was around utilization being minimal, but folks asked for a more concrete definition. That's ultimately the idea that we were trying to get at with that. We did get a lot of comments again on the 9 generics. We kept that the same, though, again, we did review the literature, and that's where we are most confident that we've reached steady state, but that is a debate that folks are welcome to have. And I think those were the only changes that we made on this section of the regulations. So this is the policy review process and final actions. So we have our informational gathering, and it has the different types of input that we can receive. It also has the process for setting the preliminary policy recommendations. And then this articulates the final actions that can be taken, which is the adoption of the final cost review report, the non-UPL policy recommendations, and the adoption of proposed regulations setting the upper payment limit amount. So again, we mentioned that we're excited about the new information gathering process that we have. So we have the public informational hearings, stakeholder council input, the technical hearings, board and staff research and analysis, and then also information from the eligible governmental entities. For our preliminary recommendations, we articulate the different information that can be used for the preliminary policy recommendation. And then also we parse out the differences between the policy actions for non-UPLs versus the policy actions for the upper payment limit. And we think this was responsive to some of the comments. We did receive a lot of comments just kind of clarifying what the board should analyze, and I think we framed it as a may analyze, but we can look at when recommending different policy options, we may look at the drivers of the affordability challenge, the policy, how the policy itself addresses the driver, the strengths and weaknesses of the policy, possible implementation issues related to the policy, and then also the potential impacts of the policy. And we do expect that to be a pretty robust analysis that's available for the board. And then the board may ultimately adopt or modify one or more of the policy recommendations. And then this notes that the final action on the policy recommendations has to happen after the affordability challenge determination is final. For the upper payment limits themselves, so this is, again, a much more fleshed out process just because this is what's kind of articulated in the regulations and the statute. But ultimately, the staff may recommend the upper payment limit as a policy option. And if we do recommend the upper payment limit as a policy option, we can analyze the drivers and the market conditions causing the affordability challenge, the ability of a UPL to address that issue, the relevant regulatory criteria, and then also use the use of the drug by the governmental entities. And then we can also provide recommendations related to the upper payment limit, including an assessment of the drivers of the affordability challenge and the extent to which the UPL may address the drivers. So then we have the process for establishing the upper payment limit. So first we can recommend methodologies and contextual information. We articulate the methodologies in B, and then the contextual information that the board can consider in C, and then the development of the actual upper payment limit values, and then the technical hearings. One thing to note is, so in B, we list out the different types of methodologies that may be used. And a lot of folks, we did receive a lot of comments on the methodologies, kind of as a concept as a whole. I think some folks had specific concerns about specific methodologies, but I think the main comments that we received basically were folks wanting more clear communication of which methodologies would be used, and then also how we would account for the contextual information. And there were also concerns with how you would go about combining methodologies, right? So, there was a lot of discussion about basically these methodologies are developed to answer a specific question, so it's difficult to pull from reference pricing and a cost-effective analysis and come up with a single number. So I think we're generally responsive to that. I mean, we appreciate the comments, and they were helpful comments to consider. Ultimately, a lot of those are implementation issues, and I think those kinds of issues will be addressed and articulated in the staff's recommendations on which methodologies to use. And then the contextual information, a lot of folks had questions and concerns about how the contextual information would be used. And I think the main staff point on this is, in general, we expect the contextual information to almost be almost increase the UPL of the drug. Like, it's almost a thing that can help the stakeholders in that it will be a reason that, like, our methodology says the drug should be this, but we should pay more because of these considerations, right? So I think it's an adjustment that the board and staff can use that ultimately I think the stakeholders will want us to include. So we think it's important to include these different contextual information and allow the board to consider them when you're setting your final upper payment limit. So, so when it comes to actually calculating the value itself, the board may select one or more of the methodologies and contextual information. You can also select a different methodology, so the staff will kind of provide our recommendations, but you can point us to a different methodology. You can also let us know how to prioritize that information. So, saying that this is the methodology that you would like to see, but I would also just like to see the results of this other methodology. You can give us that kind of direction. The staff can take that. So again, that's all kind of on the front end, just kind of general guidance on the direction that you want to move. And then ultimately the staff will take the information that you provide to us and actually come up with the upper payment limit amount. And the actual calculations themselves, and then develop the list of potential UPL values based on the feedback that we received from the board. The staff shall post the public version of the upper payment limit values in the analysis, and then the the recommendation of which one we recommend, and then the descriptor of the calculation and analyses and relevant underlying assumptions used in the analysis, such as a health outcome or threshold. And again, the idea here is we want to give the public enough information that they can provide meaningful feedback, and even to the level of debating, appropriate methodology assumptions and things like that. So that's ultimately going to be published for public comment, and the board will receive our recommendations plus the public comment on the different on that document that we put forward to the board. I already mentioned the technical hearing, so the board may convene a hearing for the purposes of receiving technical input or technical information or expert testimony. And again, this has a slightly different format because it has a very specific purpose of working through some of these technical issues we expect to encounter as we come up with the final upper payment limit amount. And then the board staff can take the information from both the board reviewing our upper payment limit calculation, the public comment on that, and then also anything from technical hearings, and revise it in an amendment. If we do make any changes, then that ultimately also has to go before the public again for public comment. And then at the end, there's the final determination of an affordability challenge, and then the final policy action and proposed regulations. So just for that, we just, again, ultimately, the board will have to finalize the affordability determination, and then if you move forward with the upper payment limit, you will publish those as a regulation. So each upper payment limit the board does will be done as a regulation. We have the section establishing and monitoring the upper payment limit. So this is where we actually articulate what the upper payment limit represents, and then also we talk about how we're going to monitor a UPL. At this point, we've said that we're going to develop a monitoring plan to monitor develop a program to monitor the availability of any prescription drugs. And a lot of folks had a lot of questions about how that process would work. And ultimately, we continue to plan, or we plan to share the monitoring plan. And I think we had this conversation with the Stakeholder Council. We're looking at both passive and active monitoring. So passive is allowing folks to notify us if there are any access issues, and then also proactively reaching out to different stakeholder groups and sampling to identify any issues on the front end too. So we'll continue to work through that and continue to invite conversation on that topic. Sure.
Thank you, Mr. Chair. So on the monitoring piece, for the state and local governments, the utilization, the availability would be readily accessible information. Isn't that right? I mean, you aren't going to have to, you certainly want to reach out to participants and consumers, but you will have, I would think, tell me if I'm wrong, a solid piece of data from the system itself telling you about any issues with accessibility or changes in utilization, anything that might have been affected by a UPL.
Yes, so there's that element. So we will have, we'll be working closely with the eligible governmental entities, and there is a number of things, everything that you mentioned, we should have ready access to. But what we'll see is what drugs were actually paid for. So you can see a scenario where maybe a prescriber wrote for a drug. If there's a shortage or an access issue, we would not necessarily see that on the claims side. So the prescriber says, oh, you can't access this drug, I'm gonna write it for something else. So we do think that there's an additional element beyond that. So we'll be tracking different utilization changes, like do coverage patterns change because of this policy? But at the same time, there's gonna be some level analysis to that. Just another example of what we're trying to identify is if there's like a product shortage, there are currently a number of surveys that are mandatory, or I guess they're mandatory surveys that currently exist to different stakeholders in the supply chain, such as pharmacies. So we're looking at if we can take advantage of those existing relationships to kind of, again, try to identify any issues on the front end. So very long-winded way of saying, I think that the eligible governmental entities can provide important information to us, and it'll be an important input, but I think we expect to do more than just that.
If I may, sorry. And I think that's extremely important because one of the concerns we have heard as we've moved forward is the accessibility of the drug if a UPL is set. I'm wondering, if we could potentially see an uptick in utilization on a drug, in fact, I expect that, because it potentially would be a lower cost to the payer. So I think that's going to be something we look at too.
Yeah, I think that's a great question. And I think that's a great point. I think we can speculate on what the behavior changes would be. But if you do make a change like this, you can expect changes in how the health system reacts. We received a lot of comments bringing up concerns that there might be additional utilization management around drugs. I couldn't tell if the comments were referring to the drugs that are receiving the UPL versus the drugs like switching off of other drugs that have utilization management to push them towards upper payment limits. So we didn't have that as a concern, though I think it's something that we would certainly want to monitor for. And that's something we would look at, is if there is a change to coverage determinations or tiering or anything like that. Those are all things that we'd be looking closely at. And because we're going to be doing it with eligible governmental entities, I think we'll be able to very directly work with them on that and identify those issues.
But just to clarify your original question, are you concerned of how that the monitoring is going to be available to government agencies and the legislature? Or were you more concerned about just monitoring, that we were going to do monitoring in general? I guess that's what I was trying to.
Right. What I was hearing was that there would be some limitations around what could be monitored, and because of availability of data, et cetera. So I was just thinking, wait a minute, if we begin, and I understand that we're beginning with governmental agencies, it seems if the data is not currently available for us to be effectively monitoring it, then we need to be able to say to the affected agencies, we need this data.
So it was more in general about monitoring as opposed to specific who can get access to?
Right,
okay.
Exactly.
I just want to make sure. Jerry?
But I think, that we have to take a look at, we could see an increase in the utilization, but still there could be problems in getting access to it in Maryland. So we have, it's not just utilization that we have to take a look at, but talking to MedChi, talking to the pharmacies and saying we're having trouble getting access to it, even if the volume does in fact increase.
I agree.
Yeah, and we do want to spend a lot of time in the development of the monitoring plan. And then there are potential implications just in terms of costs and things like that. So, for example, again, we have a lot of ideas on how we would monitor, but depending on the cost of certain things, that's part of why we're still, we'll take some additional time to develop the actual monitoring plan itself. Yep.
Yes. Thanks for this discussion and the opportunity to provide a comment here. I see a role as we go forward as well for really just making sure we're balancing the sources of input. One of the comments I'd seen among the comments received for today's meeting is concern of additional patient burden if we were to have patients as either a primary or sole source of information about burden, right? And so in this monitoring phase, I definitely see a role for having patient input, and that's where I might just want to clarify, can we use those hearings in the monitoring phase to seek additional input? So that's a question for the group. And then a question, more of a comment I would have is, what I appreciated from the comments is really just providing a good perspective on the kind of outcomes we should be monitoring for. So we talk a lot about access at the patient level, but there were comments about the impact on pharmacies and what they can put on the shelves, impact on shortages. And all of that, to me, is really important, but it also highlights that we can't only rely on administrative data for the monitoring. The concern with that and the lag has already been noted. But even if we had fully current administrative data, if you will, or other type of population health data, it still doesn't give us the broad perspective for all the actors who are potentially impacted. And so I think approaching the monitoring from a perspective of multiple sources of information for multiple stakeholders and then multiple methods for collecting that data, hearings, and so on.
Okay,
Thank you.
Jerry's got a rebuttal.
And I don't have a rebuttal, I just have a question that I hadn't thought about until now. And that is, so far, all the comments we've got have been very clear, sort of give us very specific recommendations, and they're public. We're also getting confidential data. And what if we have questions about the confidential data as board members? What do we do?
It's a great question, and I'll have to take that back to the team. The way we have conceived it is that right now it is a one-way process. We let folks know what we are asking for, they can send it in, and then we can look across the different data sources and try to reconcile them. I'll check if there's a way that we can ask for clarifications if we need them.
Yeah, so like I'm thinking, if the PBMs give us data on prices, do those reflect the full rebates? Do they not reflect the full rebates? Those kinds of questions may not be in the confidential data. So I'm trying to figure out, is there a way for us to have a follow-up questions for the confidential data?
I'll get back to you on that.
Yeah,
I'll have an answer.
I hadn't thought about it either. I would have asked it earlier.
Yeah.
Stephen?
Yeah, and I just need to note that any monitoring that we do is going to be at best 3 months, 6 months, 9 months late before anything shows up and the data is collected well enough. I can't imagine that we're going to have real-time data on pricing, to be able to push out the doctor saying, oh, there's a, sale on such and such. You can, prescribe drug A rather than drug B this week because it's going to be better for your patients, assuming that everything's equivalent. That's also the big problem is if you have equivalent drugs, then it would be nice to have you use the cheaper drug, but it doesn't always happen that way.
Yeah, and I would just respond that I think our hope, I agree with you that certain data sources will have a lag. Our hope is to also identify sources that are as close to real time as possible. We want to be able to identify any issues as soon as possible.
Yeah, I mean, for example, shortages, doctors will know that there's a shortage when they put something out and they can't get their patient get it. So certain things we'll get in real time, and other things like pricing we may not, unless the PBMs decide that they are willing to participate in a real-time and share information in a real-time sense on those kinds of things. So, some of it is we know will happen because physicians or pharmacists will tell us it's just not available. In other cases, the prices will take a lag, and we know that.
Yeah, and I think we all need to understand that we're not going to sit here today and have all the questions to all the answers. We don't have a playbook, and we're writing the playbook as we go, which is one of the reasons that it's been slower than some people want. But trying to get as much of it correct as we can to start with. But, I've been really cautious about, with legal and everybody else, about boxing us in a hole with all regulations. And I know pharma and hospital associations, all of you guys out there work in a perfect world in harmony, and you're all transparent as we are, which I'm in the private sector, so I know that's bull. But, bottom line is that we're trying to get where we need to get to for everyone to have a seat at the table and to be there. But we have to recognize going forward that we're going to have to do some things that we're not going to know the answers to until we do them. And then we'll get the answers and we'll hopefully correct it if we've done something wrong or whatever the case may be. And I think we've all got to realize that. I've sat on some of the calls with other states. Other states are, extremely frustrated, I think, with some of their procedures and what they've done, and we've been able to benefit from that, I feel. So we'll have to see how some of it shakes out. But anyway, go ahead, Andy.
And that's a nice transition into the last section of the slides, which is just your reconsideration procedures. So we provide the authority for your reconsiderations, the process for your reconsidering an upper payment limit, and then also what to do, the action on drugs where the upper payment limit is appealed or repealed. So there's 4 things that you can do. If you want to reconsider a drug, you can take no action and allow the UPL to stand. You can modify the UPL amount and propose an amendment to that regulation. You can suspend a UPL for a specified period of time and propose an amendment to prescribe the suspension. And then ultimately, you can also repeal the upper payment limit by proposing to repeal the regulation that set that amount. So here's the general process that you'll follow as part of the reconsideration process. This just kind of lays out, again, the different documents that we'll publish and the process that we'll follow. And ultimately, the idea is if the board wants to reconsider an upper payment limit, we want to make sure that you have the information necessary to make any adjustments or ultimately take the action that you need to take. The last thing we'll flag is that for drugs where the upper payment limit is fully repealed, we just wanted to flag that this basically, if you wanted to set an upper payment limit for that drug again in the future, you actually basically need to start from the beginning. You have to go from the entire cost review study process. When you do get to the upper payment limit step in the process, if you decide that the upper payment limit's a tool, you can take information from the previous experience of setting an upper payment limit into consideration, but you ultimately still need to follow the full process to get to that point from the beginning. So with that, happy to
Not to throw a wrench in this, but we don't say if we repealed a drug for our UPL, we don't say there's a quiet period or there's a waiting period for the board to take it back up again, right? Like a year, or do we say anything at all, or are we just silent?
No, there's no time restriction. There's a couple of mechanisms where if it's on the FDA shortage list, it's drafted so that it would automatically be essentially suspended while it's in that status, consistent with the statute. But there are no restrictions on if you decide to repeal one and the drug still comes up as eligible for study again, you could go back and study it and set another UPL if you wanted.
Does that make sense?
I mean, there's a self-limiting process with it where you've seen, we've started our cost review study process in March, right? And we're going through that now. So there is kind of a self-limiting element to, I mean, I guess theoretically you could then, start the process right after you repeal the drug, but ultimately the board needs to proactively decide that they want to re-engage that full process that we're going through now. So if you wanted to set a specific time, that's certainly something.
No, I just happened to think about it.
I mean, there's probably many reasons why I would do it, but probably the 2 biggest ones are a new drug enters the market that's a competitor to an existing drug, and if that happens, the price may go down, may not go down, but we'd have to monitor both of, that, or alternatively, it loses its patent and there's generic competition. And those are probably the 2 major reasons why we would reconsider a UPL, but I'm sure there's a whole variety of other ones.
Yeah. Great. So that's the presentation, and then it's up to the board on if you want to take any action on these regulations at this time.
Let me first open it up. Any other questions in regards to what Andy just went through? Joe, you've been quiet. Anything from your end?
No, nothing new from me. And just to let you guys know, I need to go in about 3 minutes. I have to go teach a class.
All right. Then I'm going to see if there's a motion on the table for approval of the draft regs.
So moved.
Motion by Jerry. Is there a second?
Second.
Second by Stephen. Any additional questions? All those in favor, aye.
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 Okay, it passes. Joe, thank you very much. Whenever you need to go, we understand.
I appreciate it. Have a nice holiday, everyone.
You too. All right, Andy.
Yeah, so I might
Annual
just
report
talk through
number
next.
5.
Yeah, so just to articulate for the board's reference, so you've approved the proposed regulations, so we will submit those. This is now means that it's going to go through the full notice and comment process. So we'll submit those to DSD. I think it will ultimately go into a register, hopefully in January. Then the public that's listening will have a 30-day comment period to provide public comment. And then the board will ultimately need to approve final regulations to be published in the register. And then after that, those regulations will become live and the board can start their process as articulated in the regulations. So thank you for the approval there. I think the fastest, just looking at the Department of State documents schedule, would probably be sometime in March. They can be live.
15th.
Yeah. Yep. Great. So we'll move to the next agenda item. So the board will remember that we have an annual report that we publish each year. And that report requires us to go over price trends for prescription drug products, the number of prescription drug products that were subject to a board review, and the results of the review, and any recommendations that the board will have on further legislation needed to make prescription drug products more affordable in the state. I think we discussed this in our July meeting, discussing if we wanted to do a deep dive on any specific policies, and the board ultimately decided that this was not the year to do that, though in future years you may want to do deep dives on specific issues and have specific policy recommendations. So at a high-level summary, we spent a lot of time discussing the work of the board up to this point and just walking through the cost review study process. We articulated that the board referred 8 drugs to the Stakeholder Council for input and ultimately selected 6 of the 8 drugs for the cost review study process. We issued a request for information for 4 of those drugs. And then we still will be issuing the request for information for the 2 other drugs, probably early 2025, so not necessarily by the end of this year. And then we also included a list of all the board actions related to the cost review study process. So talk through the studies. So again, 6 drugs are subject to the cost review study process. We don't have any results yet, so those are not published in this report. In future reports, I think we would make sure to summarize the results of each of the cost review studies. We also summarized our work on the upper payment limits and the upper payment limit action plan. So you can see the timeline here. Yeah, you can look at the different timelines and work that we did related to the upper payment limits. For the 2024 trends in drug prices, there's a series of annual reports that come out that we look towards for national drug pricing trends. And we articulated a lot of those trends and summarized them in the beginning of the report. Just to summarize some of those key findings, the average out-of-pocket cost per retail prescription increased in 2023. Aggregate out-of-pocket costs for patients increased by 6% in 2023. The list price increased by 4.9% in 2023, though this is, it's important to note that this is slower growth than prior years. Also, we noted that there's been an increase in the launch prices of new drugs in the 2023 market. Go ahead.
The premium increases?
We can look at that. And one thing
Because I hear that they're much faster than, those numbers that, you're telling me, so.
Yeah, and that's one thing we are trying to reconcile on our side. We hear a lot from our payer colleagues on the proportion of premiums that go towards prescription drug products. And it doesn't exactly map to, quote unquote, the prescription drug spend compared to overall healthcare spend. So that's something we are researching but don't have specific answers on. I do have one other quick note. We like to do this analysis on Maryland data as well. And right now, we just got access to the last piece of those data. So we may release, additional studies or findings specific to Maryland data, but that'll be separate from this annual report. So we can make that information available to the board as well.
What years are those, Andy?
A lot of these reports are published in the fall of '24, and they represent 2023 data. So there's a series of 4 or 5 reports that come out every year summarizing that data. And they come out in the summer of the year and represent the prior year, basically.
What the state employees'
Yeah, I was
premiums
talking about
are?
the state data.
Oh, state data?
Maryland.
It depends on what the data set is. So one of them, it was actually, one of the things that held us up was Medicare data, not necessarily state data. So state data has been available for state employees, but when we do our analysis, we like to include Marylanders on Medicare in our analyses for you, so, yeah.
Okay, thank you.
So I assume this is open season for state employees?
The state employee open enrollment closed, I think, but general open enrollment is still open, yes.
And do we know what the premium increases averaged were for?
I can get that information for you.
Okay.
We'll get that for the board members, yes.
Because I mean, I know for federal employees, it's quite large, and for Part D people, it's quite large. I just don't know what it is for state employees.
We can look into that. I'm sure that's a number that's available.
Well, I can tell you from a N of one of a Medicare beneficiary going through the Part D drug prices, they are all over the market, you know, and my costs can be anywhere from $16 a month to $160 a month, depending on, you know, which particular plan I want to choose. Obviously, I'm going to choose the cheapest one, but, you know, why does it work out that way? Why, you know, it makes no sense that, you know, the drugs that I'm taking costs $160 a month with one plan, but $16 a month on the other. It's totally crazy.
You bring up a great point, and I think a lot of our job is going to be educating the public on why this system works the way that it does. So,
Well, good luck.
yeah, how many years into this? Yeah.
I don't think you'll be sitting in front of us if you're good at that in a year from now.
So we will provide some additional Maryland analysis, but that doesn't necessarily need to go into our annual report. So we did identify just a few high-level trends, so we did flag. We have a section on prescription drug affordability boards as a policy option that a number of states are exploring. So we did kind of provide some of the statistics related to the boards themselves and try to summarize the work that's happened so far. We also, one of the big topics in drug pricing for the past few years, and 2024 was no different, was the Inflation Reduction Act. So the inflation adjustment seems like it's actually made some pretty significant changes on how manufacturers are pricing their drugs and increasing those prices. And then obviously the Medicare plan design, Part D plan design, has been a big topic. So starting, I think, in January 1, 2025, the out-of-pocket cost maximum of $2,000 begins. And they also have their $35 maximum for insulin. And then a topic that we've discussed multiple times is the Medicare negotiation. So Medicare selected their 10 drugs for the first cycle of negotiations. They published those negotiated prices in 2024, and they'll go into effect starting in 2026. So a lot of work has been happening around the Inflation Reduction Act. We also spent a lot of time thinking through biosimilars. So this is a theme that's been increasing over time. And one of the challenges is, so the biosimilars market is continuing to grow. And the market share of biosimilars is going up. And there's been some interesting movement in the space around FDA guidance on the interchangeability. So just as a very quick reference, the generics market basically allows for full interchangeability between the drug name and then any generic manufacturer. The biosimilars market was theoretically supposed to work the same way, but each biosimilar manufacturer can't necessarily be interchanged with any other biosimilar or the name brand biologic without approval of the physician. And that's for a number of different reasons, but that has potentially hampered how the biosimilars market can achieve savings and make that competitive market work. So there's been a lot of work in the space to try to allow for more competition and interchangeability between biosimilars, and that's something we're watching very closely. And in a space where states can take the lead, I think the FDA is slowly moving in that space, but states can kind of be on the front end of that. So we are seeing some states start to take action to allow for more interchangeability of biosimilars. And then obviously a topic that was a major part is the GLP-1 agonists. So that has been kind of the story of healthcare for the past year or so. So we did just want to do a deeper dive, kind of flagging the issue and outlining some of the issues. It's been something that the state has had to write a series of reports on. So I think MDH is exploring publishing just some descriptive statistics, and we wanted to provide kind of an analysis of what they could do, some literature they're saying in the space. Let's see. Excuse me, that slide shouldn't be on there. Sorry about that. So that's an overview of the report. It meets the requirements that we need to meet every year. I don't think there's a lot of controversial topics in this report, and no key recommendations. So it's mainly kind of serving as an artifact to reflect the work that we've done through the cost review. So happy to answer any questions that you have about the annual report.
All right, I think everybody has a copy of it. Are there any other questions? Jerry, did you have a question?
Yeah, sort of more of a comment than a question, but, this is about the interchangeability of biosimilars. And, I think it is important for us during the next year to really take a look at how the states are doing it, because we might want to make a recommendation to the legislature next year that they be pretty aggressive in allowing for interchangeability. I think that's why we don't have as many as we could and as many as that exist in Europe. So it is something that we should consider. I think we've done the right thing by writing the report this year, but I think next year we should consider making a recommendation.
Great, thank you.
When did you first start on that, Darren? 15 years ago?
Yes, Mr. Chairman, and I guess I'll be working on some more.
I think I do remember those comments and conversations and arguments. Okay. Anything else on the report? Entertain a motion for approval?
So moved.
Second. All those in favor, aye?
Aye.
Aye.
Thank you. Andy, you're 2 for 2.
Great, thank you. The last item that we have before the board today is just a quick update, and actually so it looks like we don't have any slides on this. So the last item that we have, sorry, I don't know if there's a way to zoom in on this, is just an update on the cost review study process. So we received all the data that we expect to receive, and we're in the process of drafting the documents, and we're hoping to release a public version of the data that we can share, potentially as early as for the stakeholder council meeting. I don't want to promise anything or get ahead of our skis, but it's something that we're trying to publish in the near future for the public-facing version. And we expect the board to have the opportunity to do your preliminary affordability analysis in one of your upcoming meetings. Just for your reference, we did so for Farxiga. For the 60-day comment period, we received 7 comments for the drugs that were posted on the website, and one of them specifically referenced Farxiga. And then also, you'll remember that we opened an additional comment period for trying to get more patient input, and received 8 additional comments. One of them specifically mentioned Farxiga. And then also for the request for information, we had 7 RFIs that were responsive to data related to Farxiga. So that's all information. The RFI information won't be public, but we will have kind of a public-facing version of our analyses based on the data that we've seen and received. For Jardiance, same thing. There were 7 comments received, with 1 that specifically mentioned Jardiance. In the patient comments that we received, so that was the subsequent period from October 28th to November 8th. Of the 8 comments that we received, 2 of them specifically referenced Jardiance, and then in the RFIs, 7 of the RFIs were responsive to Jardiance. So this is all the information that we are using and getting ready to summarize, and we'll try to publish public-facing version of the dossier for the public review and for the board's consideration in upcoming meetings. So I think that's the main update that we have for you there, but happy to answer any questions.
Jerry?
I think this makes a lot of sense to just focus on 2 initially, and then, expand it to the other 4 later on, but just to make sure that we have the right data and that everybody on the board thinks that it is the right data for these 2, and just keep it as simple two, I think. One would be too few, and 6 might be too many, so I think 2 does make sense here.
Great. Yeah, we appreciate that. And it's partially been just the sequence of the work that we've been doing. So we mentioned this before, it wasn't by design, but it just so happens that some of the drugs are in the same class. So these 2 drugs are in the same class. And then there are also 2 drugs that are GLP-1s. And because those classes, they're done in the class, we're able to review them in those groups. So that's why this sequencing is working out the way that it is.
Okay.
Great, thank you. So that's everything that we have.
Go ahead.
In terms of administrative update, I think I would just echo everything we've talked about. We look forward to continuing our cost review study process and look forward to continuing to work for the board.
Great. Before I go around the horn, our special guest, Delegate Cullison, any words of wisdom prior to January?
I don't know how wise they are, but I think what I'd like to say is thank you for the thoroughness and the deliberative approach that the board has taken to this work. And the staff has done an extraordinary job I think, in gathering information in a very complex context. I mean, we talked several times about the need to put some of these discussions in context, and this entire environment of drugs pricing is one of the most complicated things I've been ever encountered. So I appreciate your work on this. I look forward to, I'm excited about where we are now with respect to being able to actually get start on the work, but appreciate that it's taken us this long to get there because of the thoroughness, the comprehensive nature of the study and gathering of information. So I thank you for that and feel like we have a really good product here. Thank you.
Well, thanks for being involved and staying involved. It certainly helps us try to do the right thing. So let me go around the horn. Stephen?
No, I am thoroughly impressed by everything that we've been doing. I think it's a good idea to stick with 2 and slowly increase our aspect of drug pricing, trying to break through the Chinese walls of pricing of the various entities between the PBMs and the insurers and the manufacturers is totally crazy, and I'm surprised my hair hasn't turned gray yet. But I'll leave that for others, I suppose. But little by little, we're getting there.
Great. Jerry?
So, I mean, I think we've told you what the data we'd like. A lot of the data is very current, and, the manufacturers, the PBMs, the insurers have a lot of data that we don't have access to. And so I just encourage you to continue to provide us data so that we can make an informed decision. We're going to use the data that we have, but if you can give us better data, we would very much use it. As you can hear from the board members, we do read your materials.
Very good. Is there anything from Barry?
Yeah, just seconding the comments that have already been shared in person, have been feeling very happy about the depth of content. The content is productive, it's useful. So really just appreciating the time individuals are taking to send in those comments. Great to be at this point as well with the UPL action plan. A lot of the thoughts that I had, I think, are more operational in the context of implementing versus any changes to the current plan. So very much look forward to moving forward on that. And then once we have this in place, coming back to a cost review process to be able to include those hearings as an approach for information gathering will be very much of interest to me. And then definitely agree with Jerry on the importance of getting participation from stakeholders and providing us data, and then just letting them know as well. We hear them in terms of providing transparency and clarity as to how we would handle confidential data. That's a point that we had discussed earlier. So look forward to next steps. Thank you.
Great. And I guess that from a chair standpoint, I'd like to thank all the staff for the last 6 months. I think we've gotten better focused. I think our agendas have gotten smaller. I think we've done what we needed to do to close out the year. I think the reports are better, and I think the regulations seem to be smoother. So I appreciate all the help that everybody's done on that. Let me also thank a couple folks. Many of you don't know, but we participate with, or we intentionally partnered with the MHBE exchange because I didn't feel like we needed 15 or 20 pens. And so the exchange helps us with things like IT and HR and closeout and budgeting. And we just went through our 3rd or 4th year of a closeout. It went very smoothly. We didn't have any bad write-ups, thank God. And so I do want to publicly thank MHBE and their staff. It seems to be getting smoother each year and better. And then also MHCC continues to help us, and I know Ben's getting ready to step down, which will be a loss to the state. He's been a tremendous asset at that commission for an awful long time, but they also remain and continue to help us throughout the year on things. And it's very vital when you only have five people on board to be able to find resources like that you can either contract with or do things with. Just IT alone is a huge problem. And then going forward, we made a decision at staff meeting a couple weeks ago to move the January and March meeting to virtual. The reason really for that is this room does executive noms for those of y'all that are involved in the legislative process. When I was here, they didn't start until 5 on Monday, but they're starting earlier. And for us we'd either have to change and have the meeting in the morning or whatever. So we're just going to do virtual January and March and come back in here after they, leave in May and start live again. So sorry for the back and forth, but this room does fit us best. We can do the audio here where over at the house we can't do it for some reason. So for all those reasons, we'll be virtual in January and March. And with that, before I call for adjournment, I just hope everyone has a wonderful Thanksgiving, good holiday season. We could possibly have a special meeting, be voting only sometime in December, but I don't think that's going to happen. But we will make sure that everybody has plenty of time if we do that. So with that, let me call for a motion for adjournment.
So moved.
Second. We stand adjourned until, at this point in time, until January the 25th? 27th of 2025. Thank you.